Health services across Manitoba are provided in facilities located on the original lands of First Nations and Inuit peoples, and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation.
Good afternoon, everyone, and welcome to today's session on the Mental Health and Addictions Innovations in Mental Health and Addictions Learning Series. My name is Chad Saxon. I'm the Communications Coordinator with the Addictions Foundation in Manitoba, and it's my pleasure to welcome everyone here today. As the Minister mentioned, moving on the recommendations outlined in the Virgo report, the Manitoba government has invested more than $50 million in over 30 projects to improve mental health and addiction services in our province. Throughout the series, we're going to have the opportunity to learn about these projects as well as additional mental health and addictions projects currently underway in Manitoba. It's our hope that building this awareness will lead to increased referrals and access to the appropriate services for clients and provide a platform to promote the evidence-based alternatives, overall system collaboration, and knowledge sharing. Today, we're excited to feature the Enhanced School-Based Mental Health and Addictions Supports Project. We are joined by several members of the project team who will take part in a question and answer series session following this presentation. The Enhanced School-Based Mental Health and Addiction Supports for Youth is a new initiative that focuses on youth in grades 6 to 12. Using a high-fidelity wraparound approach, the initiative adds psychiatric nurses and addiction support workers to existing school-based clinical teams. Today's presentation will look into how the initiative allows for enhanced access to supports before requiring a referral to other community services or a regional health authority program. These additional resources are intended to reduce community clinic wait times for children and youth, strengthen interagency coordination, and provide parents and families with a voice and choice in the treatment plans for their children. So with that, we'll turn things over to the presentation and be back with all of you for questions in a bit.
Hello everyone, and thank you for attending this session on the Enhanced School-Based Mental Health and Addiction Support Pilot for the Portage la Prairie, Hanover, and Brandon School Divisions. This is a pilot program undertaken as an integrated partnership between the Hanover School Division, Portage la Prairie School Division, Brandon School Division, the Addictions Foundation of Manitoba, Southern Health Santé Sud, and Prairie Mountain Health. My name is Chris Bromley. I am the Director of Mental Health for Prairie Mountain Health, and I'm excited to share with you today what we've been able to achieve over these last 2 years as a group of agencies working towards implementing this pilot. From the onset of this pilot, our group decided that a pilot was going to fill needs and gaps in access within the system, and that we'd work collaboratively to plan, coordinate, and integrate our service delivery. All parties came to the table with what they could offer to provide direct services that are timely and where typical barriers to service delivery exist. The intended scope of this project was to help address the mental health and addiction needs of youth attending the schools in each of the divisions. It was also to provide enhanced resources that are integrated into the school clinical teams, as well as link back to the formal mental health and addiction system. Some of the key activities that were identified for us to conduct while we were in the schools would be the high-fidelity WRAP facilitation, where the student and their family is put at the center of the planning process. We're going to provide direct service provision, as this was identified as a need from the beginning and is the focus of our team in such areas as skills building, resource connection, counseling, and education. Education and support is also provided directly to the school teams and within the school community. We provide crisis consultation in the moment and when needed on things such as suicide risk and violence risk threat assessment. Also, being present in the area where the youth spend most of their time allows us to be able to connect directly with the youth while also being flexible and meeting them where they're at if there's difficulty with school attendance. The mental health and addictions nurse also serves as an important bridge between the gap between facility-based services and reintegration back into the school community. The staffing complement for this pilot program includes a high-fidelity WRAP facilitator, which is hired and managed by the school division, a school-based addictions counselor, which is managed and supervised by the Addictions Foundation of Manitoba, and a mental health and addictions nurse, which is supervised and hired and managed through the SDO that the region is, whether it's Prairie Mountain Health or Southern Health Santé Sud. So for the wraparound facilitator, wraparound is a family-driven, team-based planning process that develops an individualized plan that uses the strengths of the student and the family that the whole team takes on that effectively addresses the family's needs on a day-to-day basis. This WRAP facilitator engages the students and their family in this process while having access to the other team members to support the planning and interventions. The school-based addictions counselor provides direct service to youth and their families. They provide support to substance-affected youth. The counselor also provides consultation, support, and education to school teams and communities. The mental health and addictions nurse provides direct service to youth and their families and acts as a direct liaison back to the formal mental health system. The nurse acts as a bridge for youth being discharged from a facility and are entering back into the school community, transferring timely information and planning for the best possible transition. The nurse acts as a consultant and resource for safety-related concerns in the school and provides education and support to the whole school community. The target population for this program are youth aged 12 and up and their families. At some of the pilot sites, younger ages are served based on their need as opposed to their age. Youth and families who would not typically be reached by existing services or who experience difficulty in maintaining service provision with existing supports were also a target of the program. Tier 3 to 4 students requiring additional supports were identified as the area that we'd like to focus on, and I'll show you more on the Tier 3-4 that we discuss here. Integrating services across a school division, AFM, and a health authority, we needed to take a look at the different models of care and the different service delivery models that are used within those areas to identify needs. To work between these two models, the instructional and positive behavior support model, as well as the Virgo mental health and substance use framework, we work together through a system mapping process to crosswalk these two models to create a better and common understanding of the population we aim to serve. While we work within Tier 3 and 4, many of the activities and connections that we made in the school are also within the Tier 2 category. While there are some differences between the sites on how the referral is processed so that we can adapt to the needs of that area, each case is reviewed by the team to make sure that the appropriate services are involved in the care. If you take a look at the figure 1 on the referral stream here, it gives you a general idea of who would take the lead in which situations. So a referral would come in, be reviewed, and either the nurse or the high-fidelity WRAP or the community addictions worker would take the lead. This does not mean that only one individual would be involved in that care. They can consult with each other, move across, and be able to work collaboratively for the best care for that youth. So the mental health and addictions nurse would take the lead for things like first episode psychosis, dual diagnosis, students transitioning from a facility, and high psychiatric or complex needs. A high fidelity WRAP lead would be involved if high fidelity WRAP was indicated, if there was multi-system involvement and needed the whole team. And the community addictions lead would be primarily substance use problems for substance affected youth and youth with limited access to AFM in their community. When we look at decline referral, it would be more that this is not a tier 3 or 4 referral, the criteria was not met, or it's out of the scope of the team. Requests for consultation or case review are just made directly to that clinician. We wanted to be able to integrate these workers into the school as much as possible so that they could be a support to the school community. For students transitioning from facility, referrals are made from that facility directly to the mental health and addictions nurse. To date, these are some of the statistics that we've been able to collect from the service that we've delivered. We've been collecting adverse childhood event indicators for each referral, and on average, participants have 4 ACE indicators. The average wait time until first offered appointment from referral date is 5 days. 350 or more education and consultation sessions with the nurse have occurred. 200 plus safety and vitra consultations have occurred within the school. There's average of weekly contact per participant between the workers within this program. 60 or more students and their families are involved in RAP. An important distinction there is that when RAP is involved, it's not necessarily just the student who is identified. The family and the other siblings within the family are supported through a RAP process. 120 plus students were connected directly to the nurse or addictions counselor for direct service provision within these sites as well. I'm pleased now to have some staff and supervisors from the pilot programs be able to provide some important impact stories to give a good picture of how this pilot has progressed so far.
Hi there, my name is Lane Hill, the Mental Health and Addictions Nurse for the Enhanced School-Based Mental Health and Addictions team in the Portage La Prairie School Division. I work alongside Corey Asham, RAP Facilitator, and Jason Burnstick, our AFM worker. I have to make a note here about our appreciation of the many caring school teams in the division and their ability to work with our team to best support our students and families. We could not do this work without their expertise. Our impact story focuses on a youth and their family and the successes we have observed since becoming involved. When our team was called to further support this student and family, there are many issues affecting their ability to manage. Those are poor school attendance, lack of engagement with school staff and peers, daily substance use that impacted mental health and the ability to cope with emotions, a single parent family affected by mental health concerns, and a parent also unable to work due to the needs of their children, as well as their own recovery with physical and mental health. There were 6 ACE indicators and a family system at risk of further breaking down. So support for this family involved all 3 members of our team. Our interventions were that AFM was able to provide age-appropriate substance use counseling and information. The RAP facilitator has connected family to resources and is providing ongoing support for parent and student. The RAP facilitator has been an integral part in advocating for student and family to the school team. And for myself as the nurse, I've been providing mental health support to clients such as safety planning, medication monitoring, and skill building. My connection to client is ongoing, and I look forward to building on our achievements. So our interventions have had some positive outcomes since becoming a part of this client and family story. So the school attendance has improved and client has established peer connections at school. The relationship between family and school has also improved. The parent has returned to full-time employment, and also the student has adhered to an antidepressant medication, which is felt that has contributed to improvement in their mental health. And finally, substance use has reduced. In connecting with student and family in a way that respected their voice and choice, we have been able to see positive outcomes. Our team has enjoyed being a part of the success of this family, and we do look forward to our ongoing relationship with them. Thanks.
Hi, my name is Les O'Neill, and I'm a supervisor with the Addictions Foundation of Manitoba. I'm connected to 2 of the Enhanced Mental Health and Addictions pilots at the leadership level, and today have an opportunity to share with you the impact story for the Hanover pilot. This story revolves around a middle school aged youth who has been connected to the pilot since September of 2021. This young person lives with aging caregivers. At the start of his involvement with the pilot, had minimal respite supports in place, has a significant trauma history. He has a total of 12 ACE and trauma indicators. From a school perspective, he was not engaging. He had irregular attendance. From a CFS involvement, there was significant concern that his placement was breaking down. At the time that he got involved with the pilot, a high-fidelity RAP process was implemented. This included the school, community agencies that were already connected with this young person, and also other community supports. And what has played a significant role in the high-fidelity WRAP process has been the communication. It has strongly increased and improved amongst all the people that are part of the high-fidelity WRAP process. There are identified mutual goals, and the plans to reach these goals are agreed upon by everyone involved, and all know what steps they play in that. So what we've seen from the outcomes of the high-fidelity WRAP process and this young person's time within the pilot up to this point, has this the young person has remained in his current placement. His school attendance and engagement has increased. He's gotten much more involved in school sports teams. Integrative planning regarding safety concerns in school and home life domains have occurred. And there's also been an increased community involvement with the Outreach Center.
My name is Crystal Fleury, and I'm the High-Fidelity Wraparound Facilitator from the Brandon School Division's Enhanced School-Based Mental Health and Addictions team. The story that I'm going to share from the Brandon team is a story of a family of 7, a mother, her partner, and 5 children, ages 10, 9, 7, and twin 3-year-olds. The family was referred to our team on November 2nd, 2020, and will be graduating from Wraparound on March 10th, 2022. In preparing for this presentation, I've had to rewrite this story a few times, as each time was too long for the time permitted. I could honestly spend an hour talking about the positive and healthy changes that this family has made over the past 15 months. Prior to Wraparound becoming involved, the only service engaged with the family were mandated services through CFS and police, and crisis services in mental health. Mom was disengaged and did not have a relationship with the school. The 10-year-old had significant academic concerns, and the 7 and 9-year-old had significant behavior concerns, including several violent incident reports. At the school level, there are many supports already in place, such as functional behavioral assessments and behavior intervention plans, a safety plan, literacy and numeracy support, educational assistant, school counselor, resource teacher, building student success with an Indigenous parent worker, occupational therapy, school resource officer, school social worker, school psychologist, the speech and language pathologist, as well as almost daily principal intervention. The school had attempted to connect the 7 and 9-year-olds with mental health services in the past with no success. Our team's mental health and addictions nurse began weekly therapy with both of them in January 2021. And while it took some time and creativity, both children are engaged with their therapy. Mom and the 2 children have started and maintain medication to support their mental health. In working with her doctor in the last month, Mom has been able to discontinue the use of her depression medication without symptoms reoccurring. The team used wraparound planning to prevent a CSU admission of the 7-year-old. The 9-year-old has not had a further CSU admission since early December 2020. Mom is waking up in the mornings with her children to get them ready for school. She appears significantly happier and is taking part in self-care, joining both an online beading group and starting to read in the evenings. Mom and her partner are taking the kids to extracurricular activities multiple times per week, and Mom volunteered with CFS to help the evacuees that came to our community. Due to the efforts coordinated by the Wraparound team, Mom was able to attend a virtual ADHD parent session, and she's using the techniques that she learned within her parenting. Prior to the involvement of our team, CFS was providing 15 hours per week of in-home support, including driving the children to and from school at lunch 5 times per week. This service decreased slowly and has not been needed for this school year. Curbside busing was also being utilized to support attendance with the children and is no longer needed. The family CFS worker reports no child protection calls, despite children almost entering CFS care prior to wraparound. CFS will remain involved voluntarily through the transition from formal wraparound to the monthly meetings back at the school level, but then they also plan to close their file with the family. The 10-year-old was able to receive a psychological assessment at the school, and recommendations of that assessment were included into the needs within the Strengths Needs Culture Discovery. The 2 3-year-olds were enrolled into preschool through team planning. Mom and her partner's outlook on their children's school has changed from wanting to seek out different schools through school of choice to being happy where they are. The family has had to move and wanted to ensure that they remain in the same catchment so that their children can remain at the school. The school reports that Mom will answer the phone when they call or call back quickly and has been more engaged and responsive overall. She and her partner have been active participants in their children's school programming meetings. The Brandon team used several different measures with each participant before intervention, every 3 to 6 months throughout the intervention, as well as at the end of the intervention. Mom's seen an increase of 17.14% on Dr. Unger's adult resilience measure, a 13.74% increase on the My Life, My Strengths, My Needs questionnaire, and the children's attendance went from an average of 78.9% at the beginning of intervention to 89.6% for an increase of 10.7%. Of the 32 needs identified by the family throughout the wraparound process, 25 of those needs were successfully achieved. The remaining needs will continue to get worked on at the school level. It has truly been an honor to be a part of this pilot project and witness a significant amount of change that can be achieved with our students and families with integrated, intensive, strength-based, and participant-centered services. Mom provided a testimonial for me to share with you today, so I will end my story with her words. I am glad that I said yes to wraparound because I feel that I would be worse off now if I didn't. CFS was heavily involved with me and my family before wraparound and got a lot of reports about me. This week, CFS told me that they haven't gotten any reports in a very long time and they would like to close my file. I am able to manage my depression, I can cope with day-to-day stress, and I'm actively involved in the community with taking my kids to extracurricular activities, and I have been volunteering. Before wraparound, I stayed in my home with the curtains closed. Through this process, I have built a good relationship with the school. I feel that they are supporting me rather than judging or working against me. My kids used to get picked up every day by curbside busing, and they had a shorter day at school. Now they're walking to and from school, and they stay at school for the entire day. I used to get called by the school daily due to the kids' behavior. Now I rarely get a call. My kids are more open and talk to us about what is wrong. They also follow a regular schedule in the evening, night, and morning, and they play together in a cooperative way. Thank you.
Some learning challenges that we experienced along the way. Implementation of a pilot within the school division during a pandemic is very difficult. Our staff were very creative in ways of connecting with people and working with people where they're at, even when the schools were closed through virtual means. Flexibility is important with set parameters. Each site took a slightly different view of how to implement, but that's important based on the different communities and how things are set up in that community. Creating buy-in within the school community is integral. Integration is the goal. We wanted these staff members to be seen as part of the school community, as part of the school team, so that staff and students were comfortable with their presence within the school. It allowed us to think differently about how to reach youth and adjust with the needs. There were some challenges in knowing that it's time-limited pilot funding and not knowing when the end of this would be. Statistics collection and evaluation is difficult within the resources that we have. And we had difficulty integrating the substance use specialist into the team as the substance use specialist was part-time while the other two were full-time. Future projects that we would look at implementing as part of this would be to increase the community substance use specialist to full-time at all sites based on needs at that site. Consideration for collaboration with the youth wellness hubs where they exist as well as this pilot. Upscale the model to other school divisions and communities based on the success of this pilot. Develop an implementation guide for the hope of eventual spread. Utilize ACE indicator data for evaluation development, and train more RAP coaches to mentor high-fidelity RAP facilitators for sustainability and connections for that program. I'd like to take this opportunity to thank all of the leaders and all of the individuals who worked within this program, as well as the schools that accepted us in. You'll see the list of information of the people who were involved in this. There's been some that have moved on and changed jobs, but it's been one of the most rewarding and valuable integration, collaboration, planning projects I've ever been a part of, and I'm very happy that we were given the opportunity to do this pilot. I think we'll have an opportunity for some questions following the presentation, and I thank you all for your attention.
Excellent. Well, that was a terrific presentation, and really, really, you guys did a great job showing the success stories that that the project has had. And I would ask everybody who is involved with the project team to turn your turn your webcams on now, and we'll go into the question and answer period. We have quite a few of them here today, so we're fortunate to have a good selection from the presentation group. So easiest if just to start, if we maybe just have everybody introduce themselves quickly, and that way we know a little bit about who's all joined us. Chris, would you mind starting?
For sure. I'm Chris Bromley. I'm the Director of Mental Health for Paramount Health. Sorry, I am at home today. I'm not feeling great, so that's my explanation for my appearance and my voice, I guess.
Hello, my name is Leighton Knapp. I'm a Director of Youth Services with the Addictions Foundation of Manitoba.
My name is Crystal Fleury, and I'm the High-Fidelity Wraparound Facilitator with the Brandon School Division.
Sorry, Rochelle, I don't think we're able to hear you. All right, not coming across. Les, would you mind introducing yourself? Oh, having trouble with your audio as well, Les. Are you muted?
There we go. Good afternoon, everybody. My name is Les O'Neill, the supervisor with the Addictions Foundation of Manitoba, both with our school-based team and our youth live-in program in Southport, the Compass program.
Susan, would you mind introducing yourself?
Hi there, I'm Susan Gillis-Hammer. I'm Assistant Superintendent for Brandon School Division. I was struggling a little bit with my camera there, but I think it's all good now.
You're up, yeah. Did I miss anybody? I think, or see Cheryl. Cheryl, if you wanted to introduce yourself.
Oh, hi there, everyone. So I'm Cheryl Tremako, and I'm from Manitoba Education. And just listening to the presentation, I was just so deeply touched by the collaboration and the teaming that everyone has done to make this successful for our youth and families. And my role was basically simple. I took the conceptualization from the mental health advisory group after the Virgo team, and was responsible for connecting with the sites and the school teams, and basically sending out the funds so that this great work can happen. And I'm just touched by it. So thank you so much.
Excellent. Well, thank you very much for that, and thank you to everybody who joined us today. Again, like I mentioned, it really just a great opportunity to shine a light on another really important project in the province, and I thought you all did a very good job of highlighting that, especially the success stories. Those were very touching and great to hear. So I just going to pull up our question window here and we have a few questions already have come in. So one question we did have, and I think Chris, you kind of touched on this briefly towards the end, is will this eventually be made to other health authority areas in the province?
I'm not entirely sure if that would be part of the plan. I do know that there was discussion about that at one point, but it'd all be based on funding. We feel that this is a model that could be spread, but that would require kind of further planning. I don't know if Cheryl has anything to say from a Manitoba education point of view, but at this point in time, the pilot is what was funded, and then we can see where we go from there.
We had another question. Where would someone receive the wraparound training that you had mentioned?
I can speak to that question. So wraparound is relatively new to Manitoba. There was kind of a big push in 2016, and that's when I got my training. But there was a lack of wraparound coaches. So when you get the wraparound training, it's a 4-day classroom training, and then afterwards you receive coaching for 1 year after that. Included in this pilot, Cheryl Chornico was actually my individual coach, and then I had group coaching with Stephanie Enns, who's the Manitoba wraparound lead out of Norwest. And she is a trainer as well as several other workers in Norwest Agency, and she's currently mentoring me to become a wraparound trainer in Brandon. So I will be the first person outside of Winnipeg that I am aware of that will become a wraparound training trainer.
Fantastic, that's great to hear. So we had another question and a comment. Really nice to see the future of integrated care. How were the families chosen? And if these programs continue, how do you expect referrals or youth selection might go?
So families to be chosen, if the question is chosen for this presentation, it would be using some of our more impactful stories and some of our success stories for it. If it's for how do you become involved with this, the referrals to become involved with WRAP and through the team would mostly come through the school teams directly to this enhanced school-based team. That would be, we have a referral form and some information just helping guide what types of people would be a part of it. It's all voluntary as well. And that's generally how people become involved, is through the referral from a school team. But if it's a transition from a facility, then it can come from the facility such as Compass or CATC or MATC. The referral can come in that direction for that transition point. I see Leighton might have his mic off. You might have something to add as well. Or did I make
no,
that up?
I didn't have anything in particular to add, but yeah, I mean, I think that I mean, one comment I just wanted to make, and I don't know if there'll be any questions to this effect, is, you know, I thought Crystal's story and just the specifically that impact on reducing involvement with child and family services is so key. So as I think about this project, I mean, that's one of the most significant indicators. If involvement with CFS can be eliminated or reduced, you know, I mean, to be able to share a story like that, and I'm sure there are so many others from the last few years, and in some cases, you know, we won't really even know, because if the work is preventative, then CFS may not be involved in cases where they might have been. So, you know, that's certainly an indicator to me, like that's already shown the value of this model. And however the work kind of plays out, when there's this level of connection with youth and families in the school, you know, with mental health, addiction, and wraparound services, I anticipate we'll continue to see these sorts of results. And I mean, that's an incredible story, and to be able to show tangibly that CFS involvement has been reduced, and the family is able to function much more independently in a much more healthy manner, that's extremely encouraging. And so I think that, you know, that's from my standpoint why I hope this type of model will become standardized provincially.
Well, thank you for that, both Chris and Leighton. We had another question, and I believe this was touched on, but we could maybe just go to it again. Where did the funding come to run the pilot project? And I think, Cheryl, you had mentioned that this was a provincially funded project through education.
Yeah, I could just expand on that a little bit. So as you stated, Chad, at the beginning of the presentation in your orientation, that after the Virgo report, there was money allocated for mental health ideas and innovations across our province. So some of the money came from the federal government, some of it came from provincial, and I think certainly what happened after the Virgo team met is there was a mental health advisory group that was formed with people from education, justice, families, and health, and that they made some decisions around some innovations. And so that's where the money for this pilot came from, was from that bilateral federal funding. And good news was announced just last week that we do have the funding commitment for one more year of this pilot in the existing sites. And that was just at this point, I think, from our provincial players. So it really does say a lot, and it recognizes that this project had some real value in terms of integrating. And as stated throughout the presentation, the families that benefited from this intervention were those ones where, you know, the school, they keep the school team members up at night. They're wondering why, you know, the family didn't engage with AFM or didn't connect with mental health. And by bringing the resources into the school team and the power of hearing the family, really positioning the family to be the central focal point of their care. That's the mantra from High-Fidelity Wrap, is voice and choice, really made a beautiful difference to just really hearing what the family needed and validating that. And then from that, you can see just through the stories, some real magic happened. So we're gonna knock on wood that with or without funding, we certainly hope funding is allocated. If there isn't funding, what a hope would be is that people maybe can realign, or post-COVID, we might not want to hear the word pivot anymore, but we see good work across school divisions in Manitoba to have the partnership, certainly with mental health and addiction. So thank you.
Well, it's great to hear. Obviously, it's something that, I mean, the success stories point to the work and to the, you know, the results that are taking place. So hopefully this is able to continue for the foreseeable future. We had another comment, and I think it sounds like maybe a bit of a tech issue. It says, "Hi all, I may have joined using the incorrect link. My name is Kathy Obb, and I am I'm one of the regional managers for community health in Southern Health, and have had the pleasure to lead the pilot, particularly the two nurses in the Hanover and Portage La Prairie school divisions." Okay, so sorry for the issues there, Kathy, but thank you for making your presence known here. You're actually coming up under a different name, so obviously there is a bit of a technical issue there. We had another question. So currently, can you access this in Winnipeg or Brandon only? So no, you had mentioned obviously Portage and then also the Hanover School Division as well. That's correct. Those are the correct locations.
Yes, Brandon School Division, Hanover School Division, and Portage La Prairie School Division.
Right, that's what okay, great, thank you. So another question here, you mentioned receiving referrals from MATC. How do clinicians at MATC or other organizations access your service for youth? Is there a referral form? Does the referral come from the community school?
So yeah, I had referenced it, but we hadn't actually experienced it. But it's the idea was any facility-based care to be able to connect directly with that nurse, to be able to transfer that information and help with the transition to schools. So generally we hadn't connected in with MATC as of yet. We have had with Compass and CATC, but there is a referral form and we can get the direct information and have the nurses reach out to MATC if there is an opportunity that somebody's returning to one of those areas from MATC. That would be the what we'd be looking for expansion of how that would work for this project.
This is Cheryl. I'm just wondering if I could add to what Chris said. It would be important, I don't know, but I'm imagining that in some of the areas, it could be that a young person was at HSC, for example, on either maybe the eating disorders unit or an inpatient bed after a trip to ER. That could be a possibility. So quite often people think of child and adolescent mental health in Winnipeg as just the MATC programs, but it could be HSC, it could be an MATC program. Certainly when we think of some of the youth with neurodiverse brain-based challenges, like some of our youth with autism, for example, they may be involved through the school program or through the clinic, and some of those may go back to the school divisions. But yeah, Chris, your point is really valid that the nurse could be involved if someone, let's say, had a stay at HSC here in Winnipeg.
Mm-hmm. If I could just add as well. So here in Brandon, we did do transitions from our crisis stabilization unit at CATC to Brandon School Division. And those referrals are different than the original referral stream, which comes from schools. So our psychiatric nurse, when receiving a referral from health of a student that has been at the stabilization unit, she will follow that student for 2 weeks, having almost daily contact with the student, the school, and the parent to ensure that their planning and programming is in place. But after that 2 weeks, if the school feels that they would like regular involvement from our psychiatric nurse or anyone else on the team, then they would fill out an additional referral at that time.
Okay, great. Okay, we had another question. When referring to WRAP, are you referring to Wellness Recovery Action Plan, or is this another program through education?
I think there's 3 WRAPs actually, but I'll let Cheryl and Crystal say which one this one is.
Okay.
Yeah, so this is Cheryl. So that is true, Chris. And in our presentation, we have to be really careful. So a lot of people use the word wraparound programming. And so a wraparound in some terms is just used across lots of systems. Circle of care is also a term you'll hear where there's multi-agency planning involvement. And the WRAP that you just mentioned is a specific model of organizing, kind of a recovery-orientated framework. And the one that we're referring to in our school divisions is the one that Crystal Corey and our WRAP facilitator in Hanover, Curtis, are trained in. So it's High-Fidelity WRAP through WRAP Canada, and it's a model of intervention that has principles and values that really keep the fidelity of the model and the integrity of the model is really, really having the client in the voice of the family heard as the center and integral part of the model. So it's a big shift for a lot of players. But yes, it's a specific intervention training model that is being used when we talk about WRAP in this pilot.
Okay, great. Well, thanks for clarifying that. You did touch on this earlier, but we had another question, but if you want to just touch on it again, we had a question regarding how someone would go about the training. So that seems to be of interest. So maybe if you want to just mention that one more time.
They would contact Norwest Co-op in Winnipeg. They have several trainers there. I know that they have a training request form that you can ask for. And they can let you know what prices are. They also have coaches on staff as well for the 1 year of coaching that's required after the 4-day classroom training.
Fantastic. Okay. And we had in the question we had, hi, I'm Jill Brown, Manager of Child and Adolescent Mental Health in Brandon and area. Can't get the camera or mic working, but just wanted to introduce herself. She said that they're lucky to have such a strong team in Brandon. Also, we had a question, is this model available in all schools in the named school divisions?
Yes, other than the grade 6 to 12 aspect of it for Hanover and Portage La Prairie School Division, so not the grades under that. And then in Brandon, there is some that would go under grade 6 based on what the needs are of that individual. So yes, other than within the parameters of the age range.
Great. Don't see any other questions at the moment, but I was just kind of curious, the model for this that you guys worked off, was this something that you kind of came together yourselves, or was it modeled off of another project that you had seen?
I would say that this model came majority from the work of this team in putting it together, but there is a model out of Ontario that has a mental health and addictions nurse attached, but they're not necessarily as integrated. We had some communication with them within their local health integration networks about how they implemented it. We also had a conversation with some folks in Nova Scotia that have a similar piece to it, but the direct service provision integration into the school team was a creation of more of this group. The rest of those models were more on a consultative, provide services into, but not necessarily integrate in. I'm sure there are similar models other places, but the one that was provided as an example for us to work off of was the Ontario one, which was a bit more consultative as opposed to integrative.
Great. Well, thanks. I'm not seeing any other questions from the audience. So if you do happen to have a question and you'd like it answered, please enter it into the question box. I will just take the moment to mention that this video will be online. We'll be posting it probably most likely tomorrow. We have a site on our AFM website. It's called to reach it, you can go to afm.mb.ca/MHA learning series, and that'll take you to the correct page, and we'll have all the we'll obviously have this video, but all the other presentations that have taken place since we began last year. Lots of really good information on some excellent projects taking place throughout the province. So again, that's afm.mb.ca/MHA learning series, and you'll also find information on the upcoming presentations that we have. We've started our phase 3 of presentations. Will begin on March 23rd, and that's going to be the, I believe for that one, we are fortunate to be featuring the, excuse me, I'll just grab my notes here. Our next session, as I mentioned, March 23rd, will feature the Métis Community Addictions Response Team, which provides support and services to families who are experiencing parental substance use and/or mental health struggles which impact parenting. So again, you'll be able to find more information on our webpage for that. So again, not seeing any questions. So obviously, I think you guys did a very good job with your presentation, and questions afterwards to cover off everything that was out there for the audience. So again, I'll just mention that the next presentation is March 23rd, and that'll be the Métis Cart project again. So with that, I'll say thank you very much to everybody who attended, and most importantly, thank you to everybody who was involved with this presentation and who's involved with this project. Obviously, like you showed some great work taking place, and we really appreciate everything that you're all doing. So again, hope everybody has a good rest of your day, and thank you again.